Good morning again, everyone, and welcome to the second webinar of our Health and Housing Summit webinar series. Again, I'm Dwayne Spencer, President and CEO of Habitat for Humanity of Greater Memphis. We're happy to see you here. Thanks for joining us. So I hope you guys all had a chance to join us on Tuesday. If not, I encourage you to go back and watch the recording. Our first panel kicked off the summit with an incredible conversation that really helped set the stage for the next several weeks. So some of my takeaways from that session were that aging is a universal experience if we're all lucky, right? Older adults are an asset, not a burden, and we should treat them as such. We should consider the curve effect. And we all benefit when we create spaces for those with disabilities. Those who set policy are often not the ones affected by it. I found that really interesting. The housing sector does not have enough resources, which is why we need the healthcare sector to help. That's something that I've been saying for a long time now. We need to consider the human-centered and lived experience as we try to figure this all out. Also consider the functional goals of the senior, as well as social determinants of health. And you'll be hearing a little bit about that today. Also, the need for evidence-based interventions. And that's where we're leading into right now with this session. So today, we're going to dig a little deeper into relevant data and how to connect it to solutions. And so, as I said Tuesday, we at Habitat are practitioners. That's how we see ourselves. We work on the ground and in the field with our clients. We're all about taking action, but we want that action to be backed by evidence. So before I introduce today's moderator, I want to again thank the sponsors who helped make this event possible. So thank you again to the Tennessee Housing Development Agency. Thank you to Wells Fargo. And thank you to Methodist Le Bonheur Healthcare, as well as our advisory group, who provided a lot of wisdom and expertise during the planning process for this event. I also want to encourage you all to share, tweet, and post about this event. So registration is going to remain open through our last session, which is February the 4th. And we'd love to have more people join as we move through these conversations. And if you post, use the hashtag TN Health Housing Summit or the hashtag Memphis Habitat. Also, today's session will include slides. And so our team wants to recommend to all of you to, in order for you to best see the screen, we're spotlighting during the panelist presentation. They recommend that you set your Zoom on speaker or gallery view, okay? So that when the slides show up, you can see them. And you can adjust that in the top left of your screen right now if you want to go ahead and do that. So onto the panel. So today's moderator is one of our own from here at Memphis Habitat. Her name is Chris Reeder-Young, and she is our Senior Research and Evaluation Manager. Chris received her Master of Arts in Urban and Medical Anthropology in 2007 from the University of Memphis and specializes in qualitative, asset-based, community-driven research and evaluation. In her 11 years at Habitat, Chris has led all research and evaluations focusing on neighborhood revitalization, affordable home ownership, and critical adaptive home interventions as social determinants of health and community well-being. She's also worked collaboratively with other local social scientists, economists, and think tanks to promote holistic and objective analysis of Habitat's impact. Back in the day when we used to travel and I would attend conferences around the country, when I would share with people that we had an anthropologist on our team, they were really surprised by that. And I'm happy to say that we actually have two anthropologists on our team. Chris is our urban anthropologist, and we have another staff member, Laura Anderson, who is our medical anthropologist. And Laura actually oversees our capable work. And you'll hear a little bit more about capable from our friend Alice Bonner of Johns Hopkins in just a few moments. So at Memphis Habitat, we believe in the benefits of collecting data, analyzing it, and then applying it to applying what we learn. So just a few reminders. Again, use the chat to say hello, tell us who you are, why you're here if you want, and use the Q&A function to send your questions for the panel, okay? And then the team is gonna share those questions with Chris, and she'll pose them to the panelists at the end of the conversation. All right, so I am now gonna turn it over to Chris Reeder-Young. Chris, thank you.
Thank you so much, Dwayne, and good morning, everyone. I would like to welcome you to the Health and Housing Summit panel, Data-Driven Solutions, Critical Research that Catalyzes Community Change. As Dwayne shared, I'm an anthropologist and researcher. I've been with an affiliate for almost 12 years, and I'm very, very lucky to be moderating this panel with so many incredible speakers today. Just as a reminder, you guys can drop questions in the chat box at any time, so we can have those ready to go at the end where we'll have a Q&A session. Now, we all know that using research and evaluation is crucial in developing and sustaining healthy housing programs and policies. Evidence-based programs can encourage positive and equitable outcomes for the older Americans that many of us are really lucky to be able to serve. Today, we're going to hear from researchers and practitioners from the fields of health and housing, and they're going to share more about the evidence-based data that their organizations use and how those data points can be applied in senior community programs. Like many of you, my hope is that we are all able to learn from these researchers so that we can create and replicate sustainable programs and policies that help Americans age in place healthily and equitably. So with that, I would like to welcome Dr. Jennifer Molinsky, Senior Research Associate with the Joint Center for Housing Studies at Harvard University, Dr. Alice Bonner, Director of Strategic Partnerships with the Capable Program at Johns Hopkins University School of Nursing, Dr. Brian Rahmer, Senior Policy Fellow with the Joseph R. Biden Jr. School of Public Policy and Administration at the University of Delaware. So we have lots of fantastic content to dig into. So let's go ahead and kick it off with Dr. Molinsky. Dr. Molinsky, can you share with us what exactly is the Joint Center for Housing Studies, and what are the types of data that are used for influencing healthy housing policies?
Yeah, thank you so much, Chris. Thank you, Dwayne, for having me. It's a real pleasure and an honor to be here. I'm going to share my screen here. Get us going. There we go. Right, so the Joint Center for Housing Studies is a 60-year-old research center at Harvard. We are joint between the Kennedy School of Government and the Design School, the Graduate School of Design. And we are dedicated to advancing understanding of housing issues and informing policy. And we have traditionally done this through the analysis of data, big data sets like the American Housing Survey, the American Community Survey that are collected by HUD and Census, but also through original research and increasingly also through qualitative research. So 7 years ago, we began working in the arena of housing and aging. And this has led us to other data sets that have more of a health angle, like the health and retirement study. And we've also been doing more qualitative work, including interviews and work that aims at identifying promising innovation and practice. So a big part of our work is really talking about trends, issues, challenges, sort of helping people make the case that this is an important issue. And we have our reports, the older adult reports that you see here are our 4 signature reports on the topic, but we have lots of other articles and resources on our website. And I invite anyone listening to please visit, download. So we spend a lot of our time making the case, and the managing director of the Joint Center sometimes jokes that we can be seen as a Joint Center for bad news, right? And that we're identifying a lot of the challenges that are out there. So increasingly, I'm also trying to lift up some of the solutions. So we're also looking to practice, to work that many of you are all doing to find out what is working on the ground. My job today is to share some of the high level trends with you that we've gleaned from our analysis, but in keeping with the theme of the panel, I'll also pull back a bit to talk about the data that we track. So I'll start with some overall trends describing older adult households, tenure, finances, and then move into several areas of challenge that we're looking at particularly closely. So our own projections of future household growth really led us to put an emphasis on the housing needs of an aging society in our work, and this has become a core area of our work. Our projections show that by 2038, over a third of households in the US will be headed by someone 65 or over, and 12% of all US households will be headed by someone 80 or over. This is really unprecedented. And you can see in this chart, the oldest baby boomers are turning 75 this year. So in the past few years, we've seen a big uptick in the number of people in their early 70s and mid 60s. But in the next couple of decades, in the far right, those three bars at the very end, we're going to see a huge growth in households headed by someone 80 or over. In fact, we anticipate that this will double. And at this point, we can really expect to see rapidly growing demand for living environments that are more supportive of older people with physical challenges, who live alone, who have limited incomes to spend on housing. So while we've been seeing a big growth in the older population, I think it's the next decade and after that we're going to see the real need for housing that is more supportive and more tied to healthcare. One implication for this growth at the oldest ages is a rise in single-person households. Among households headed by someone 65 or over, 86% are either couples without kids at home or single people. It's like roughly half of each. But the share of people living alone rises with age, so that by 80 and over, it's 57% of that group who live alone. So as the leading edge of the baby boomers reaches 80 in the next decade, we will expect more single-person households, as shown again in the far right bars. In fact, by 2038, we project the number of people 80 and over living alone in the community will double to around 10 million. Now, 11% of older adults who had their own households also have family living with them. So this is most likely children, sometimes grandchildren, sometimes other relatives. In addition, many older adults do not head their own households. They live with other people. They live with their kids in their households. So all in all, 20% of older people live in some kind of multi-generational setting. And as you can see in this chart, multi-generational households are more common among Black, Hispanic, and Asian families than among white families, likely for both cultural and economic reasons. And as the nation's population grows more racially and ethnically diverse, we're likely to see more multi-generational households. So together, the housing needs of a multi-generational household and those of a single person are obviously very different, but both are important for us to consider as growing household types. Most older adults are homeowners. 80% of those 65 to 79 own their home. And as we know, for those who have the opportunity and who choose to own, there can be benefits in later life. Owners tend to have more stable housing payments than renters. And as I'll show you in the next slide, owning also helps people build wealth that can be important for financial stability in later life. The homeownership rate does dip down when people are in their 80s and over, as some switch to renting in order to downsize, have less maintenance or greater convenience. So those are the downsides of owning that people sometimes move to get out of. But ownership is not evenly distributed across people of different races and ethnicities, as these charts show. And since the recession, the Black-white homeownership gap seen in the dark blue and the light blue lines is at a 30-year high for those 65 and over. Another trend we see in homeownership is that among those 50 to 64, the homeownership rate is lower for all races and overall today than it was a decade ago. This age group suffered more losses to homeownership during the foreclosure crisis. And as they move into retirement, it's unlikely we'll see much rebound in that. And so we expect that in the future, that 80% homeownership rate will actually be a bit lower, and there'll be more renters among the older population, a greater share of them. As I said, homeownership can provide wealth building opportunity for those who have the opportunity to become homeowners. By late life, the disparities in wealth between owners and renters are quite stark. The median wealth for a renter age 65 and over is just $6,000. In comparison, owners have a median wealth of $343,000, of which $170,000 is in the form of housing equity. An owner's median income is also considerably higher than that of renters. But it's important to note that low-income homeowners generally have most of their wealth in their homes. They have very little non-housing wealth. In 2019, older owners in the bottom 25% in terms of income had just $20,000 in terms of non-housing wealth on median. So I'm going to turn now to several challenges surrounding older adults and their housing, the first of which is affordability. So we measure affordability as the ratio of one's housing costs to their income. And those paying more than 30% of their income in housing costs are considered housing cost burden. And housing costs include utilities. And if you're an owner, it includes insurance and property taxes. In 2019, 10.2 million older households were cost burdened, an all-time high. 5.1 million of these were severely cost burdened, meaning they paid more than half their income on housing. Now, lower income households are more likely to be cost burdened, as are renters and as are owners with mortgages. 55% of renters are cost burdened, 40% of those with mortgages are. 15% of owners who have no mortgage are also cost burdened, and they're obviously not cost burdened by their mortgage payments, but they're cost burdened instead by the combination of utility taxes and insurance, which can still obviously put people in that position. We know that those who are cost burdened spend less on necessities like food and out-of-pocket healthcare costs like prescription medicine. This analysis compares the expenditures on basic necessities between low-income older adults who are affordably housed, paying within 30% of their income, and those who are paying more than half their income on housing. And you can see the stark differences in what they're able to outlay for food, for health, retirement if they're still working, and transportation. And of course, living with the constant stress about paying for housing also has physical and mental health ramifications too, which research has documented. There are a few affordability trends I want to highlight that are some sort of things that are happening right now. First, more older owners are holding mortgages than in the past. In 2019, 42% of owners who are 65 and over had a mortgage with a median balance of $86,000. This is up from 3 decades ago when it was just 21% who had debt, and a median balance then was $18,000, and that's in today's dollars. So those are directly comparable. And this includes 27% of owners aged 80 and over who have mortgages, up from just 3% 3 decades ago. So this is definitely something of concern. And older adults are also holding greater amounts of other forms of debt, even student debt, raising concerns about financial security in older age. Another troubling trend is that the income disparity is widening among older adults, just as it is across all age groups in the US, with the biggest gains going to the top earners, while those at the bottom are barely holding steady. For those aged 50 to 64, there's an additional concern that the median income for this group is equivalent to what it was in 2000. This group has recovered much more slowly from the recession, which suggests, again, that like with the homeownership, this is an age group approaching retirement age in a less advantageous position than predecessors were at the same age. And we're also seeing that homelessness among older adults is on the rise, particularly in the generation of younger baby boomers, those born 1956 to 1964. This group has historically faced more economic disadvantage than the older baby boomers, and again, during the Great Recession fared worse. So meeting the challenge, all this challenge of affordability, is of course no easy feat. And Dwayne mentioned the lack of sufficient resources to do so. And as we know, housing assistance is not an entitlement. And according to HUD's worst case housing report, at last count in 2017, we serve 38% of those low income older adults who qualify for assistance, leaving the rest unserved, including nearly 2 million who are severely cost burdened, live in severely substandard homes, or both. And unfortunately, we expect that the numbers who will be eligible will increase in the future. The older population is growing. The income distribution is not shifting in a favorable way, will leave more at the bottom. And our work at the Joint Center has documented that cost burdens have been creeping up the income scale at all ages. So all of this really, really calls for a new infusion of resources to sort of even to keep serving the third or just over the third of older adults that we do is going to be a challenge. The second challenge relates to accessibility within the home. We know that the incidence of disability increases with age, as shown here. Data also show that disabilities occur earlier in life for those with low incomes, for Black older adults, for renters. though there is some convergence at older ages. So some may need accessibility features and supports in the home earlier, but need is great across the entire older population at older ages. However, very few homes have basic accessibility features. In this chart, we looked at just 3 features of accessibility: single floor living, a no-step entry into the home, and halls and doors that are wide enough to accommodate a wheelchair or someone using a walker without assistance or with assistance. Only 3.5% of the nation's housing stock has all of these in combination. Single family homes are among the least accessible forms of housing. Only 2.8% of the nation's single family housing stock has the 3 features listed here together. And this is important because most owners and even 30% of older renters live in single family homes. I want to take a moment here to talk about this data. This data is from 2011, which is the last time that HUD and the Census Department did a comprehensive look at the accessibility of the nation's housing stock. And there's a lot of reasons to believe that this data is over-optimistic, that in reality, the housing stock is even less accessible than this. More recent data collected by HUD and Census has looked at the fit between people in their homes. So rather than look at the stock as a whole, they're looking more at whether the person in the home right now can use that home. And these results are from 2019 and show the share of people by age who have difficulty getting to or using various features of their homes. People over 75 are represented in the green bars that are the tallest in each case. The remedy here, I think, is 2-pronged. It goes back to ensuring that over time, our housing stock offers more universal design and is built to be adaptable so that it will meet the needs of more households in the coming years. And there's lots of policy avenues to do that. But second, we need to create this better match between individuals and the homes they have now, which is a topic I will leave to others because this is exactly what they're working on. I know Alice will talk about it next. A third challenge relates to the needs for services and supports delivered into the home that many will need at some point in their lives. Today's most people rely on unpaid assistance, but for various reasons, we anticipate that more people will rely on paid care in the future. And as we know, this can be costly. This chart is just sort of a back of the envelope look at the cost of in-home supports and assisted living and nursing home care at the national median costs, and how they stack up next to the median income of renters and owners. And you can see that most of these would just eat up most, if not all, of the income in a given year. So then we turn to wealth. And in terms of tapping wealth, the chart I showed earlier noted that the median older renter in the US has wealth of under $6,000. That would pay for 2 months of a homemaker or home health aid service and less than 1 month in assisted living before that person's net wealth is entirely exhausted. Owners fare better, particularly if they can tap their home equity, but this exercise imagines that someone would use all their wealth for care until that wealth is entirely depleted. It's also based on a median homeowner. Low-income homeowners have far fewer assets, as I've discussed. And the bottom line is that care with housing is beyond the reach of many older adults. And it's not just low-income households that are challenged. The cost of care mean that middle-income people are having difficulty affording both, either paying for care in their home or being able to afford an alternative like assisted living. Research in 2019 projected that within the decade, there will be 14.4 million middle-income older adults who will have high healthcare needs and functional needs, and more than half of that group won't have the funds to pay for the care they need. So I'll let others speak to solutions, many of which promote wellness that can help reduce the need for care. And emphasize lower intensity settings where possible. So providing care at home when possible rather than in a nursing home. But again, I will leave the solutions to others at the summit. A final challenge that I'll only touch on here is ensuring that people have the support services and amenities that they need where they live. And this is a challenge in all geographies, but low density locations can create extra challenges for efficient service delivery. Yet between 2000 and 2017, low density portions of our metro areas had the fastest growing populations of older people. This is not necessarily because older people are moving to these places. It's rather because they already live there and they have now aged into the 65 and over category. Older adults, in fact, move less frequently relative to the rest of the population. And when they do move, the vast majority move locally or within state. And so we also know from surveys that most older adults report wishing to remain in their current communities as long as possible. So the question is, how supportive are these communities where people live now? One may have an affordable and even accessible home if one is lucky, but can you find ways to remain engaged, avoid loneliness, and get the support you need within the larger community, no matter where you live? Could you move within your community to a home that is more accessible or smaller or less expensive so that you can retain those ties? So there's a whole range of policy and urban planning actions in these arenas, from age-friendly efforts to different types of care delivery models. And again, I won't dive into these, but just point out that the data show that there is going to be a growing need at a density where it is a little bit more difficult to provide the services. So to end, at the Joint Center, we think of housing as a platform for older adults' health and well-being. Affordable, safe, accessible housing, well connected to a community and needed supports can help people flourish. We need to work on the challenges from both the housing and the health policy angles. So again, I want to thank Habitat for bringing together advocates, researchers, practitioners, and policymakers from both sides to try to make this happen. So thank you.
And thank you so much, Dr. Molinsky. I think that those numbers really hit home with many of the folks who are in the audience, and that they are now currently responding to some of the trends that they're seeing in their states. And it really highlights the urgency to develop data-driven programs and future policies. So thank you so much. So next, I would like to welcome Dr. Alice Bonner, speaking of data-driven programs. Can you tell us more about the research that Johns Hopkins has used, and then how it's designed programming for seniors who are aging in place, as well as experiencing disability?
I would be delighted to. Thanks. Chris, can you see the title slide?
Yes, I can.
All right, great. Well, welcome everybody. We're really glad to be here with you today. And I believe I may be joined on this call by one of my colleagues, Dr. Deborah Ph.A.N, who's our Director of Implementation and Evaluation. So you've got two of us on the call today, and we're really glad to be sharing information with you. I'm going to give just a brief overview of the Capable program. Some of you are working with Capable now, so you're more familiar than others, but we want to be able to share kind of an overview with everyone. And then I'm really going to focus on some data and share some data, which is really part of the panel today, part of the purpose. So, there's a few very fundamental principles with the Capable program, and function and functional ability is one of those principles. And what we find very often, I've been a nurse practitioner for many years. Many of you are clinicians or have been working with older adults in different capacities for a long time. But in the health system, we don't often focus on function, not as much as we think is important. So that's part of what's behind the Capable model. Is it really helps to focus in on what's most important and what matters to the older adult, to the participant. So this slide is a little busy, but it's telling us it's sharing some data that we think is important, and particularly if you're talking to a CEO or a CFO or somebody that you're trying to partner with and talk to about, funding and why it's important. On the left side of the slide, you can see here that where that circle is the relative risk of being in the top 5% of healthcare spenders. And I know this slide is a little bit old, but these numbers haven't changed significantly over time. And what you can see as you go up toward the right-hand side of the slide is as you add 1, 2, or 3 chronic conditions, the relative risk of being in that high spender category increases. And then as you add functional impairments to that, it goes up even more. So function is really important, not only in terms of quality of life for all of us as we age, but also in terms of high spending in healthcare. And we want to be able to direct healthcare dollars as much as possible to everyone who could possibly benefit. So, we have a number of stories from the Capable program, and this is a woman who was, again, she's pictured here. That's not her actual picture, but there was this woman named Mrs. B, and she was 85 years old. She lived in inner city Baltimore and was one of the participants. And, she'd been a homemaker, a housekeeper for lots of people in the neighborhood for many years. And, as she got older and into her mid-80s, she had pretty severe arthritis in her hands, in her knees and her hips. And so she couldn't go up and down the stairs anymore. So her family brought her clothes downstairs, and she was kind of living in her living room. And you can see underneath in this picture, instead of a closet, they put her clothing into this sort of makeshift area. And the problem was it was held closed with safety pins. And so with her severe arthritis, she really couldn't manipulate the safety pins to get her clothing in and out. So she wore the same clothing a lot of days and didn't really like that situation. When the capable team came in, the occupational therapist, the registered nurse, and the handy worker, they were able to work with Mrs. B and, work on exercises and work on adaptations in her home and so forth. And by the end of the 4 months of the program, she was actually able to go up and down the stairs again, and they were able to use the upstairs the way she wanted to do that. The other thing you can see on the right-hand part of the slide here, I'm sure these steps are familiar to anyone who's from the greater Baltimore area or a lot of our cities and towns, but you can imagine when these steps get wet or snowy, they're even more dangerous. And you can see already they're very dangerous. And so we do a lot of home repair and home modifications with steps and stairs, both inside and outside the home. And then on the bottom, you can see where the floor has been repaired in her apartment. And that is another area of very common repairs that can make a difference and reduce risk of falls and can really help to promote mobility. So those are just a few examples from one case. This is a slide that is just telling us, again, the circle at the top, you can see the participant, the older adult at the center of the care. And what's critical is that the older person drives the processes. They set the goals. They are their own goals and things they want to work on. They are part of the action plan development. And then the occupational therapist, registered nurse, and handy worker each have a role in the program. But again, I think what's really important about Capable, as with many other programs you all are involved with, and certainly is a very big focus with Habitat and other housing organizations, is, it's really person-directed and person-driven. So again, in Capable, we always start, as many of you do in other programs too, with what are the strengths that the person already has? How can we build on those strengths? And again, it's more directed and focused by the client than just person-centered. The program is about 4 months. Sometimes it goes to 5 months. There's 6 visits by the OT and 4 by the RN. And one of the really key elements of the program is those two professionals work extremely closely together. They communicate often by email, by telephone. They share information back and forth. And that's really part of the, if you would say, the magic of a program like this, and many other programs too. It's that close interprofessional relationship. People ask about costs of the Capable program, and over the 10 years or so that Dr. Zanton, who's the creator, has been gathering data, the average cost across sites turns out to be approximately $3,000. Might be a little bit less, might be a little bit more, depending on local factors. And of that $3,000, about $1,300 is for the handy worker part of the program. So might be, purchasing supplies, for example, that are needed, and paying the handy worker for their wages. So, the vast majority of the cost of the program is the salary and benefits of the registered nurse and the occupational therapist. So this is a slide with a little animation here, and it's showing you that in the beginning, the occupational therapist goes in, does an assessment of the apartment or the home and the person, and then figures out the fit between the person and the environment and where there could be some interventions. And then the handy worker comes in and they come up with a work order together, the OT, the handy worker, and the participant. Everybody has to sign off and agree on, what needs to be done. And then, there's other visits by the occupational therapist, as we said, and the nurse comes in after the first 2 visits, usually by the OT. Again, it's flexible. And the nurse is going to focus on things like medication and, optimizing medications and pain management. They work together, the OT and the RN, on exercises and so forth. So there's a lot of really good close collaboration. And a lot of motivational interviewing and appreciative inquiry and approaches to how we talk with older people about what they want and how we can support it. So those are all the visits throughout the program. And the handy worker usually is there for either half a day or a day, depending on what needs to be done. So I think we talked about all of these things. The one aspect on this slide that I do think is very important is, when we talk about unleashing someone's motivation, and what we've learned very much over the last 10 years of the Capable program is sometimes older people, especially if they've been in the hospital, and frankly, this is people of any age, so it's not unique to older adults. Once they've been either in the hospital or they've had a intercurrent illness, it can be hard for them to imagine getting back to where they were before. And so, they've lost some confidence and they're not sure they even have the ability to do what they really want to do. And seeing people come around and gain that self-confidence and that self-efficacy and be able to do things that they really didn't think they could do, that's really where you say there's something special about this program if we can do that. And we've got testimonials and videos and people who have talked on camera, and we get a lot of inquiries from the press, from the media, and we try to tell the story about the group of people for whom this can really be a beneficial program. This map is a little bit old now, but it does show you that on our website, we have an interactive map and we keep it updated. So as we add new sites to the program, we add them here on the map. And so we have about 33 sites right now. We have a handful, about 4 or 5 that are actually research sites. So we're still collecting research data from those sites. And then we have around the edges some of the organizations that have historically been involved with the program as well. This is an example. This is something Deborah F.A.A.N has worked on quite a bit, which is some of the data elements that are part of the program. And sites tend to select the data elements that they think are most important for them to track. We have a few that we ask about, the number of people who've been through the program in the year, the number of people who've completed the program, those kinds of things. But for the most part, we try to keep the data burden at a minimum because we know that there's a lot already that people are asked to collect. But we do like to look at functional level, like activities of daily living before and after Capable, instrumental activities of daily living, things like that. So here's a couple of slides that, as I said, we wanted to present that show some data. So these are from papers that have been published in journals such as Health Affairs. And this is showing the ADL and IADL limitations and how they changed with the Capable program. So the green is where there's been improvement. And you can see for the activities of daily living, almost 75% improvement in this study. And for the IADLs, about 65% improvement. So we continuously try to work on these things to get those numbers even higher because we think there is the potential for even more sort of improvement in the program itself over time. This is showing us changes in depressive symptoms on the left. And so that's almost 53%. And home hazards on the right is really significant number that, 77% improvement in home hazards. And, the aspect of the depressive symptoms, I think, is something that we're still thinking about. If there's 30% of people who say their symptoms have worsened, what's that about? Is that because we drew attention to it? Are they measuring it differently, et cetera? So we are continuing to think about and work on that. So this was an important study, and this was also published in Health Affairs, and it was by Sarah Ruiz and colleagues, and she was, again, at the federal government at the time. And there were about 4 or 5 different HCBS programs that were evaluated for cost savings. And for the Capable program, the cost savings was more than $2,500 per person per quarter. So that's about $10,000 in a year, and that actually persisted over 2 years of study. So, if you can save, $20,000 over 2 years with the Capable program, and of course, more importantly, improve people's quality of life and the things that are important to them, that's a really significant savings at the Medicare, federal level. So this kind of information is what's really useful when you're trying to talk to folks about, whether or not the Capable program might be appropriate for a particular community or region. And then this is on the Medicaid side. So that last slide I showed was about the savings on the Medicare side. In the Medicaid program, the important numbers here are the bottom 2 bars, the orange and blue bars. So it's showing that in the capable or treatment group, there was significant savings, mostly in terms of inpatient and also long-term days that people were in a nursing home, for example. So when you add these two things together, the return on investment for Medicare is about 7-to-1, and the return on investment for Medicaid is about 3-to-1. So that, taken together, significant cost savings to major payers with the Capable program. So these are the kinds of numbers we want to continue to build and continue to do research to build the evidence for the Capable program. And then finally, this is from a fairly recent study, 2019, about the satisfaction with a number of aspects of the program. So people were asked, whether or not there were differences that were a great deal of difference in their life, not at all different, made things worse, whatever. And you can see the green bars here are the ones where people said something made a great deal of difference to them. So, continuing to be able to live at home, gaining confidence, helping to care for themselves, things like that. They think the program would help others. So in terms of spreading the word to other folks in the community, recommending Capable to other people is a very significant metric. So we do these satisfaction or experience of care surveys at the end of the program. And then this is just a summary slide. I already talked about the Medicaid and the Medicare savings, and also, there's some significant savings in the Medicare ACO programs. And, you can see here at the bottom right, 90% of people said that they felt, they were living safer and more independently. So those are also very important metrics, we think. And, Dr. Zanton loves this slide. She, she had someone say this to her, that if I had 10,000 tongues and they could all speak at the same time, I could not praise the Capable program enough. So not every person says this, but there is a lot of very positive feedback about Capable. And, we take all of the feedback together into account, and we use it to kind of reshape the program and think about specific communities and specific needs. Dr. Molinsky talked so beautifully about, some of the challenges that we're all seeing in communities with increased elder homelessness and low income older adults, and people being in less dense areas now for a number of reasons, and the accessibility of housing. So if the housing stock doesn't have very many single family homes that are accessible for people with different challenges, that makes it really hard to stay home. So those are all aspects that I think relate very much to a program like Capable and other home and community-based programs. So again, in summarizing here, this is a program that looks at function, and, people want to be like this gentleman, working with a younger person or doing the projects that they really enjoy. And we want to make sure function is addressed because it is modifiable. This slide has all of the articles that I referenced, and so please take a look at some of these. They're also, most of them are posted on our website. And here's our team. These are all the folks, again, Dr. Zanton, who's the co-creator and the director of the program, Dr. F.A.A.N, Evelyn Gustave, who's our director of our clinical training specialist. So with that, I will stop sharing my screen, and Chris, I'll turn it back to you.
Thank you so much, Dr. Bonner. Capable really is a holistic and inclusive program, and it really highlights the value of person-centered care and how it can impact healthcare savings, it can impact costs of the individual and to their families. We want to be able to serve all of the Mrs. B's out there. So thank you so much for sharing. And next, I would like to welcome Dr. Brian Rahmer. So Dr. Rahmer, we can't do this alone. We cannot work in silos. Partnerships are going to be key. Can you share more about how social determinants of health and the work that you've done around connecting sectors has inspired common impacts for older Americans and the folks who are serving them?
Sure. Thanks, Chris. And thanks to Habitat and to the organizers and sponsors for having me and a couple of my colleagues on the panel here today. And also just a quick shout out to my fellow Delawareans. I saw some folks from Kevin Smith's shop at Newcastle County Habitat for Humanity. So keep up the excellent work there. So Chris, your question is a very important one, and I want to reiterate my comments really around two core first principles. Number one, that when we think about data and the use of data, how to organize data or translate data into, practical action, we have to understand that is, I think, fundamentally a political action. And that's a small p political in that definition, in the sense that, the decisions that are made, either choosing to use data or not to use data, are really centered around values and value propositions of those decision makers. And that can look really different in different parts of the country, in different ways and across different time periods. A lot of that is certainly why we have sort of this living legacy of racist housing policy in this country that has manifested in many different ways through health inequities that we see not only today, but will continue to see in the future without significant structural change. So when we think about the role of community partners in this mix, I think what we have to really sort of understand is how to build the power of those community partners to not make the case necessarily through good data and good research and evaluation. That's always going to be important and always going to be sort of a foundation in which to build community action and political action off of. But I think what we have to recognize is that community partners oftentimes have been segmented or sort of atomized when they're put into the mix of sort of a dwindling public finance environment, or grant funding environment, or philanthropic partnership environment, where they're sort of encouraged to compete with one another for a relatively small amount of funding to do relatively small projects that oftentimes are relatively short-lived. And when we think about particularly the nexus between health and housing, when we think about the formal healthcare sector, oftentimes we're talking about hospitals and health systems at the regional level, for instance, as well as the payers, oftentimes managed care organizations in the Medicare realm for older adults, certainly, and also in the Medicaid realm for folks with disabilities and LTSS, populations, et cetera. And in that regard, the folks with the resources oftentimes hold the cards, and in a society like ours here in America, and certainly when we sort of narrow down at the state level, and I think a good example of this is the recently approved block grant in Tennessee, for instance, Medicaid block grant in Tennessee that CMS approved. When we think about sort of who holds the cards in terms of the power dynamic there, in terms of resources, we're oftentimes trying to make the argument or make the case to the health system that, these, community-based programs or projects are going to help you reduce your, ED utilization, for instance, and lower costs, in value-based payment arrangements and so forth. And we certainly, as you can see through, the Capable program, through the SASH program, through a number of different support programs that have been implemented over the years and over the decades, and the strong evidence and research that are around those things, of course, they work, and they fundamentally improve the lives and oftentimes improve the well-being of the older adults that are a part of those programs. And so I think at that point we have to ask our question, we use these data, we use this information to prove the case that we need action on the social determinants of health. But the next sort of element to that question is, do we want action on the social determinants of health? And that is really where community comes into play. I think we've neglected in the population health space for way too long the need to organize and build the power, help to build the power of not just housing-based partners like the Habitat Network, like CDCs and other folks that are doing this incredibly important work, affordable housing providers and certainly developers, but also the interdependent and adjacent service delivery providers, the residents that are in communities that oftentimes are pushing back on affordable housing development and so forth. Building and recognizing the power that these community-based organizations can have when they work together in a network sort of setting to really shift those power dynamics in terms of the resources that are being brought to the table. We all recognize that healthcare in this country is incredibly expensive. The argument can certainly be made that it's unnecessarily incredibly expensive for a number of different ways, including administrative costs, et cetera. But also, we also have to consider the fact that looking at this as a pie that's shrinking in terms of the total amount of money is perhaps not the right way to look at it. Some work that I'd been engaged in previously in the city of Baltimore, for instance, was really centered around the idea of bringing senior affordable housing developers and service providers together under one sort of network, so to speak, to organize, think about the kinds of information and data that they consistently gather and ask of their residents, the kind of lived experience that these residents can bring to knowledge building in the context of making a value argument to healthcare sector partners around the need for improving the kinds of services and consistency in those services that are being delivered. And certainly working in that negotiation space in terms of understanding what information the housing partners bring to the table that matches up with or perhaps fills in the gap of really vital population health services that are being administered formally by healthcare sector partners. Having that sort of authentic engagement in that regard and utilizing a bridge organization, for instance, or an organization that sort of sits in the middle and helps to create the space for that authentic engagement, that negotiation, that data sharing, that building of the case for the value proposition, I think is vitally important. Habitats, for instance, are suited to do that kind of work. The organizations that are adjacent to the habitats and to many of the smaller community-based organizations at the regional level are well suited to do that. Research, institutions that are part of sort of community engaged elements of universities, for instance, land grant universities and other things, can be really strong advocates in that space as well. But the bottom line is really, building the collaborative network power of community-based partners to really be representative of the full population within a particular region. This is a question of scale when we think about the difference between sort of a pilot or a demonstration. Dwayne had asked this question in a previous green room conversation around sort of when is enough data, right, to move. And I would make the argument that, there's plenty of information and data to operate off of today. There has been for quite some time. Many of my colleagues on this panel have shown us that information, the trends, the strong evaluation of these programs that have been implemented, et cetera. And oftentimes even that is not enough to help a decision maker, change sort of the value proposition and say, we want to invest in X, Y, and Z in order to achieve these outcomes. So again, this idea of organizing and building the power for community-based organizations to, for lack of a better term, put the pressure on institutions at the local and regional level to look at this question of social determinants of health in a different way and say, look, we've been doing this work day in and day out on the ground at the grassroots level consistently for a long period of time. We have a track record of showing the improvement in quality of life, health and well-being, other kinds of economic outcomes, et cetera. And collectively, we can bring this proposition to the table and, and put it in front of payers, for instance, who are becoming incredibly more competitive in the social determinants of health space, bringing it to hospitals and health systems that even now, I think in this liminal space of COVID and post-COVID recovery and resiliency planning, can be a very strong case to make that doesn't necessarily have to rely on this question of, do we have enough data and how do we present it? The future, hopefully, I think for many of us, given the challenges that not just the last 10 months have showed us, but the sheer amount of inequities that we know have existed prior to COVID hitting, but now sort of the veil has been lifted and it's in our faces now. The food lines, the cars that are sort of backed up, just so that families can feed kids. The threat of eviction in many of our communities. Not just the homelessness issue, but now also the social, emotional, and substance abuse issues that are sort of building upon the despair and the alienation of millions and millions of folks being out of work and so forth. These leverage points today for systems change are going to become, whether or not we decide to choose a living legacy of well-being or continue the living legacy of despair and inequity that has sort of been highlighted by the COVID epidemic. I'll sort of wrap up my comments here now by saying that control over destiny at the individual level and at the community level, I think, is probably a really significant place to situate translating data to action. And what I mean by that is we know that economic precarity, poverty, the struggle that many folks in the first tier and second tier sort of ladder of economic mobility face on a day-to-day basis limits our freedom. It limits our ability to control our own destiny, both individually and collectively. And the need for the structural changes that will allow for that kind of individual and collective freedom to be realized is where I think many of us are interested in putting our efforts and our action. And many of the housing partners across the country, the Habitat affiliates, all the way up through the major not-for-profit intermediaries, et cetera, I think recognize this. And I think with not just the changing federal administration, but a lot of change happening in various state legislatures at the ground, at the local level, I think our communities are realizing this as well and want to help drive the train, so to speak, be the conductors in helping to facilitate these changes. I'll stop there, and hopefully we have a lot of time for questions.
Yeah, thank you so much, Dr. Rahmer. When we look at the types of housing data that Dr. Molinsky shared, and then the types of evidence-driven, applied, partnerships, programs that Dr. Bonner shared, and then we take a look at strategic plans to get really authentic support for common impact, it feels very overwhelming, especially if there's not a lot of senior support in the city or state that you're in. So I felt like that Baltimore example really highlighted some of the insight of how to incorporate data for and build the case for strategy and partnerships. And like you said, it was based on lived, authentic experience as the pillar. And I think that's very, very significant. And I think it also helps healthcare systems figure out how they can fit into the bigger picture and really serve in the community. So I very much appreciate that, Dr. Rahmer, so thank you. So we have about 30 minutes left. I was going to pose maybe 1 or 2 questions to the group, and then we were going to open up the floor to panelists to share questions. Dr. Bonner has addressed some of the questions that were asked in the chat box already. So if you have anything else to contribute, just type your thoughts into the chat box. I want to go back to the panel. And if those of you who are joining us today didn't have a chance to join us on Tuesday, in the opening panel on Tuesday, we heard about the curb cut effect from Sarah Cantor, who co-created a firm called Greater Good Studio in Chicago. And the curb cut effect is a concept that teaches us that when laws and policies and programs are designed to benefit the most vulnerable groups, it protects and benefits all of us in that community. And we use the example of putting in a sidewalk curb for a person who is in a wheelchair may benefit other folks who are accessing the community with a bike, a scooter, maybe pulling a suitcase, maybe you're pushing a child in a stroller or using a cane. And so that kind of stimulated some thoughts on, you know, since we can expect so many individuals, so many Americans to be aging in the next couple of decades, maybe focusing on seniors, whether they're economically disadvantaged or not, can improve the way we look at housing for Americans more broadly, right? So if we are all aging, we're all lucky to age if we are able to, it seems that that would kind of contribute to some collective futures of America and what housing policy looks like. Why wouldn't seniors be at the cornerstone of the way that we design all housing and all modifications? So I'm going to bounce back to Dr. Molinsky and ask this question because you shared so much in perfect detail, all these really cool statistics that really paint the picture of the trajectory and what does affordability look like, what's the racial disparities among individuals who are renting and aging, homeowning and aging. I was wondering if we're going to inform better housing policies and programs with seniors at the cornerstone, what would you say would be the relevance of incorporating the voices of aging Americans? For example, you know, is it important to use qualitative data that inform senior programming or qualitative evaluations that improve or highlight client experiences? So going from the numbers heavy palette to more of the storytelling and the narratives. And that question is for Dr. Molinsky.
Yeah, I mean, first, I just say on the curb effect, so many of the trends that I showed are true, very true for older adults, but they're reflecting trends that are across all ages. So a greater variation in household sizes and composition, you know, so that everyone can benefit if we just have more housing options, right? Besides the single family large home in a suburb. So I think that there's many, many ways in which the accessibility, the housing affordability, the availability of lots of different kinds of housing is really relevant. In terms of your question, ideally, I think there's a lot of iteration between qualitative and quantitative data. And I think as a researcher, I guess I would discern a little bit between anecdotal stories, some of the stories that are of client successes like Dr. Bonner shared, and then the qualitative data that you might collect in an interview or a focus group project or something like that. And not to say, Dr. Bonner, that you're also doing that. So, but there's a whole range of qualitative data, right? And I think all are really important. The anecdotes I hear often drive my research questions, send me to the data to go say, is this happening everywhere? Is this, is this true? Is this a universally shared experience? I think the danger is that I'm a particular person in a particular place and I may not be hearing all the stories. I'm only hearing a sliver of people's experiences. So I think that's where it becomes wise to go back and forth between those and then to sort of structure some of those studies that go out and capture more people's voices. So we are doing more interviewing work, focus group work to sort of to feed the voices of older adults directly into our work. And we're not practitioners on the ground. So this is, for us, this is sort of a step that we're taking. And of course, in advocacy, the power of a story, I think in combination with the data is incredibly compelling. And my fellow panelists can speak to that. But hearing the story of Mrs. B is more compelling than me telling you that 75% of the country doesn't have a no-step entry into their home, right? So, but in the combination of this is how it plays out for one individual is very, very powerful. So.
Yeah, absolutely. There really are powers in the storytelling and the narratives that we try to blend even here at the Memphis affiliate. So Dr. Bonner, I have a similar question for you. The basis of CAPLE is that it's person-centered. And we, as you can tell in the chat box, we have a lot of affiliates across the country who are implementing Capable. But here's kind of the pickle. Even though habitats aren't really generating the medical data and they're handling the healthcare data and the ADLs and things like that all the time, they are able to implement some pretty cool qualitative person-centered evaluations and surveys. And I was just wondering, do you think that habitats that are implementing Capable pilots across the nation are contributing to a knowledge base that can one day influence broader aging policy in America? Because I don't know if habitats always I don't think we think of ourselves as being kind of generators of data, but these surveys and these narratives are still significant and can contribute to broadening the way that we serve Americans. So I was wondering if that was something that you felt was useful or can maybe expand and impact things for American citizens.
Yeah, so that is a great point, and I love that you asked that question because we spent a lot of time thinking about this on the Capable team, and it's one of the reasons why we really make an effort to capture the voices of the people in the program. It's totally different myself or Jennifer or Brian telling stories versus Mrs. B herself being in a video or in slides and her voice actually coming through, or the voice of a care partner, somebody who's working with an older person. But the stories from the field are really powerful data, and they are qualitative and they're contextual, and they help us understand what's really happening with a person. This is a person-directed program. It's got to be about people. It can't be about systems and processes and data, although those things are all really important. But ultimately, we've got to hear the voice of the individual person. And for everybody on the phone, I think you guys have probably had the experience of, you can't always help someone to be able to get to the Capitol or get to the State House, to be able to give testimony or speak to a congressperson, a senator, a representative. And that makes a difference. Or, going to town meeting in some town in whatever state you live in and be able to actually speak to the selectman or the mayor or whomever is a decision maker about the town. And those things are really important and they drive change. We had a relatively small city here in Massachusetts that was trying to figure out how they could become more age friendly. And they figured out by doing a lot of, focus groups and asking lots of questions that people who needed to use the bathroom frequently couldn't find public bathrooms in the downtown. So that led to them having restricted mobility. They couldn't go downtown if they couldn't find a bathroom and they needed it. And so it started out, we were thinking about older people who might have challenges, but it turned out it was young parents with little kids and toddlers who were like, this is great. Now we have a list of all the bathrooms. They generated a list of all the places where they would say you could use the bathroom in the town. Another aspect was there was an overnight parking ban. So people who were caregivers, who were home care workers, were parking their cars overnight and getting tickets because they were with an older person in their home or apartment. And so the town heard about that. They said, well, we can't have that. And they changed the municipal ordinance so people, could put something in their windshield and they wouldn't get a ticket. I know those sound like really small things, but they're not actually small things, and they make a difference. So, to all of the, the data and the programs and services that everybody here today talked about, it's wrapping it together and saying we are an age-friendly community, or we're a dementia-friendly community. And that means, we are actually thinking about this. We're intentionally planning so that people can stay in their homes longer, stay in their neighborhoods, figure out how to live their lives the way they want to. So I don't know if that totally answered your question, but I think stories from the field are like gold.
Chris, can I just quickly add on to Dr. Bonner's comments? Because they were wonderful, wonderful comments. Is that okay? Okay. Yeah, so I think Dr. Bonner's super, right and astute in the way that she framed the connection between sort of individual level storytelling or individual action and the method of stewardship that those of us in positions of privilege and power can utilize to help facilitate that change or bring those stories to places of influence. It also ties directly to this idea of the sort of curb cut mentality, or, for lack of a better sort of framing, I like to call it sort of a health in all policies approach, right? But the idea here is that for individuals to realize that the civil action or the civic muscle that can be used to create a list of all the public bathrooms, right? To have that be a part of the conversation. That civic muscle is like any muscle, right? Because it gets stronger and it grows the more you use it. So even things at that level translate into, we really can make a difference, right? If we work together, if we think about how to make this change in a more sort of collaborative and organized way. And I think, thinking about that model in the context of, the curb cut mentality or the health in all policies approach kind of brings us back to this notion that if you work to make change in improving sort of the overall well-being of individuals within a population, and those changes can be translated through data research, storytelling, et cetera, into policy change or investment, to facilitate and to keep those changes going. It's then very, very difficult for decision makers to start to rip that away, right, in the future, right? Once people realize that these sorts of investments and these sorts of benefits can accrue and really make an impact in their lives and their neighbors' lives, and that it improves quality of life and well-being, et cetera, becomes very difficult then for others to kind of tear that out from underneath them. And that's really sort of this I think notion of centering the person in the context of their relationship and interdependence with the community around them.
Yes, absolutely. And I love the way that you described a civic muscle and kind of building strength within it. And that actually answers the question I was kind of gearing up to ask you. And that really painted a beautiful picture of, how we paint this generating, producing data, the types of data, implementing it, and then we can, act as a collective, on the ground to make change, because that has been a hiccup in these processes, is how do we make systemic change? Dr. Bonner mentioned about the concept of age-friendly communities. We are thinking about individuals who might have bathroom and toileting limitations and how that changes and how do we listen to the people. We will have a panel that highlights age-friendly communities and states later in the summit. So please, if you haven't already registered, go ahead and do that. I'd like to open up the floor for questions, and I will move through as many as I possibly can. Let's see. So this looks like this is a question for Dr. Bonner. So Dr. Bonner, for Capable, are most of the program sites primarily in cities, or some of the programs running in rural areas?
Great question. The answer is both. The original program was in inner city Baltimore in a very low income, challenging neighborhoods, but a lot of the sites are in places like Austin, Texas, Chicago, California, again, Memphis, Tennessee, and we also have some pretty rural areas in Iowa, for example, Alaska and Maine. So it's a variety. There are unique challenges in rural areas, lots of which have to do with transportation and people being very spread out, but we are trying to learn in those areas.
Thank you, Dr. Bonner. And I'm wondering if maybe collecting data in aggregate on folks who are living in rural areas might be a challenge for those of you working at think tanks. I didn't know if that was a challenge to maybe collect data on people who are living in rural areas or not. Dr. Molinsky, is that a challenge to see underrepresented stats in those areas?
Yeah, I mean, data on housing quality is tough. We struggle with this. I mentioned that the last time that the census and HUD collected comprehensive data on the accessibility of the stock was in 2011, and now they're doing something different, which is also incredibly valuable, but looking at the match between people and their house. But it's less informative about, you know, what's going on with the house. And there's a variable that, you know, variables that are collected every year in these census data sets that talk about, you know, is there a hole in the roof, and is there a, you know, the basic, is there running water? And a very small share, you know, show up as inadequate or so, but it really hides so much, right? We just don't have the greatest data on this. And this is something that we struggle with all the time. And we know that some of these issues are certainly salient in rural areas, and we just don't have a great handle on things like housing quality beyond, you know, the couple of measures that the census collects that, you know, one of the issues too with the accessibility is that it is difficult for someone who does not have a disability to assess their own house, right? So when you say, do you have a no-step entry into your house? Are you counting that step at the vestibule? Are you counting the steps that are to your front porch? Are you counting the steps that might be halfway up your yard from the slope up that, you know, from the street? Like, these are things that, and this is a reason I think that HUD and census, you know, that I said that data is probably over optimistic, right? So that people might say, sure, I have a no-step entry, but in fact, it would be really difficult if someone were trying to use the home who is a wheelchair user. So for all these reasons, data on the stock is tough, and including in rural areas.
I understand that very much. So I guess, Dr. Rahmer, thinking about the intersection of kind of role dynamics and your concept of how to implement strategic partnerships and look at the power dynamics of implementing some of your programs, what are the differences that could exist for developing strategic partnerships and plans for seniors in cities versus maybe rural areas?
Yeah, that's a great question. It's incredibly important. I think a lot of it when we think, I think we have to sort of consider the interdependence of various social determinants of health, not just housing as it relates to health and well-being. And a lot of this in rural communities is infrastructural, you know, issues, whether it's information and transportation, as was already sort of highlighted, but also even the ability to sort of build upon the natural ties to the land and to that particular region that folks that are living in rural communities really feel. There was a recent paper that was in Nature, I think this was last year, sort of considering the language and the framing that is typically used when we think about, this was sort of at the height of the conversation around the Green New Deal and sort of environmental equity, right? And the sort of connection between that and economic development, and particularly in rural communities. And so this paper was examining sort of the framing aspects of climate action in rural communities versus urban and suburban communities. And the bottom line was really that the folks that were living in rural communities, a lot of these folks were older adults, understood and valued the need to transition to something that is much more amenable to protecting the land, protecting the environment, protecting the earth. But it was the framing, and it was the conversation around the framing that mattered the most. So I think when we consider the sort of the at a first principles level, what people want, right? They want, you know, they want a good quality of life. They want a better future for their children, perhaps, than they've had today. And they want to be able to sort of feel good about their legacy and the work that they're doing. And I think that is fairly universal. When we think about the differences between geographies or the differences between race or class structure, I think those first principles are pretty universal. And I think the question becomes, in the context and the interdependence of the different kinds of structural issues that people face on a day-to-day basis, how does that context shape the framing for a path forward, right? And I think that is, again, tied to this idea of civic muscle. How do you work with individuals and communities to be able to develop the opportunity to control their own destiny and control the destiny of their health and well-being for the future.
I very much agree. And I see that, all three of you have shared, sort of where the gaps are, either in civic action or programming, or even some limitations in data, so that we can start to create some pretty significant bridges, so that we can, again, change our trajectories to serve more Americans. So we have about 5 to 10 more minutes left. Dwayne will be closing us out, but I wanted to ask one short question. I haven't seen any more come in, but I was wondering what the role of advocacy is in developing policies. So is there a lack of advocacy about data and policy? Like how do we, as folks, practitioners on the ground who see these stories and see these numbers and see these conditions between rural versus city folks, how do we share that, and how to create opportunities to, again, kind of flex our civic muscles? And what does that look like? And that might be a really long question, too long for the end of the session, but if maybe you could tap into some of those points.
I'll try to be quick because I feel passionately about this, Chris, and really, I think even more so over the past 10 months, specifically the past year with the COVID crisis and the way that public health information has been shared or not shared or changed or framed. I think, we see this dynamic between the old idea of, well, if I'm a researcher or an evaluator, I need to be completely objective and remove myself from sort of the context of what I'm studying, right? To this new horizon, which I think many folks, including folks in the social sciences space, anthropologists like yourself and political scientists and others, public health researchers and ethnographers, et cetera, have understood very well for a long time, which is that, data is political, whether or not you want to call it qualitative data or quantitative data, or frame it in a combination of those things. It's political, and we have to recognize that, because if we want the act of generating data, gathering data, understanding data, evaluating that data, and then translating that evaluation into practical action, I think we can't segment those things and silo those things like we do so much in other parts of society, whether the siloing of social determinants of health or the over medicalization of population health or whatever it might be. I think those things have to be consilient and they have to be interdependent. And I think the current crisis has made us certainly recognize that more so, whether or not that sticks around and continues to be the case as, the vaccine does its work and, more and more people can return to a safe social existence, is another question. And I think that's really, the job of folks that are on this call and have been a part of this summit, and, the colleagues that they work with day to day to make sure that that's the case.
Absolutely. So about 2 more minutes left for Alice and Jennifer. Any thoughts? How do we advocate data and policy?
I'll jump in really quickly and say my personal opinion is that we have absolutely lost a step with advocacy. We do not have the strength and the knowledge and the skills in the advocacy communities that we have had in the past. And it is not because we're lacking the, dedication. People are just working super hard. So that's not the issue. The issue is we have to come together as a country and get advocacy organizations working collaboratively, not working against one another. And we have to have that collective voice where we're all saying the same thing the same way, because that's what's going to convince legislators to do something different. So Jennifer, what would you say?
I would say on the research side, I feel like the health and the housing people we're at a party and we're in the same room and we're talking to each other, but we haven't really totally figured out how to leverage each other's work and really work together to make the case. I think we we still have our own acronyms and we have our own understandings of the different programs. I'm optimistic that in this next administration, there'll be more of that. And I feel like in my time at the Joint Center, you know, the last 10 years, there's been a remarkable movement toward, you know, coming together, and we now are working with people in public health that we never worked with before, but there's still a lot to do there.
Yeah, absolutely. Well, thank you so much. We're at the end of our panel. I would like to thank Dr. Molinsky, Dr. Bonner, Dr. Rahmer for their expertise and time today. You all have highlighted significant points that can help other agencies replicate and improve the use of research and evaluation and programming. So a reminder, we're going to have these presentations available to you. So I thank you for joining. And Dwayne, why don't you close us out?
All right. Thank you so much, Chris. Panelists, thank you for your time and your expertise. This was really amazing. You gave us a lot to think about, including a lot of hope for me personally that there is sufficient data right now, even though we know we'll continue to collect and analyze and share to prove out the effectiveness of our work and validate investment, hopefully, in the future from the healthcare sector. Dr. Bonner already shared that capable of saving Medicare $20,000 a year per older adult served. That's huge. You know, consider the multiplier effect of that dollar amount. Here in Memphis, we've served 1,100 seniors, and ours have been with mostly critical home repairs, again, averaging $10,000 to $13,000 each. So imagine the actuarial analysis of even 10% of these seniors having reduced ER visits, fewer hospital admissions, and delayed entry into assisted living facilities. I'm confident that our impact is in the millions of dollars. And other than the senior themselves, the healthcare industry really is the other primary beneficiary. In fact, we've begun to include our senior repair impact benefits in our social and economic impact studies, which Chris leads for our team. So we collect data on long-term care savings, medical cost savings, in particular fall prevention, and utility savings. And so think about what that benefit would look like when we calculate it across our entire state and across the country. To us, it seems hard to argue that the cost against the benefit. So I'm really feeling more confident about how data can inform and influence policy change. I'll just need to be sure I take Alice and Brian and Jennifer with me when I do my outreach and advocacy. Brian, I loved one of your final thoughts, living a legacy of well-being. That's where we should all hope we end up, right? Again, you've all reinforced my belief that data is critical and absolutely essential. Attendees who are still with us, thank you again for joining us today. I hope to see you again next Tuesday as we make our way through these 9 sessions. Next Tuesday at 10:30 Central for our 3rd session, when we take it from the national perspective to the state perspective and focus on Tennessee, the volunteer state, and what we're doing across our footprint. So be on the lookout for an email from our team by the end of this week with access to this week's videos, presentations, and links to the resources we've been talking about today. Thank you again, and I hope everybody has a wonderful afternoon. Take care.
Thank you all.